today's topic is about PET-CT in thrombus imaging. Introduction. What is thrombosis? It is the formation of blood clot within an intact blood vessel or within a blood vessel, that is called thrombosis. So detecting and characterizing and monitoring thrombi are clinically critical because it can lead to various diseases like stroke, MI, everything. And it can also be a leading cause of mortality. And if we look at conventional imaging like ultrasound, Doppler, CT angiography, MRI, all those conventional imaging, they provide anatomical and hemodynamic information, but they do not directly probe the metabolic or cellular activity within the clot. So there comes the role of PET-CT. So PET-CT in thrombus imaging, the main uses are to detect occult thrombosis, which are undetected in conventional imaging, to differentiate thrombus from pure thrombus or the bland thrombus from tumor-associated thrombus, and to estimate the age or activity of the thrombus. So if it's acute clot, it will have more inflammatory cells and more metabolically active than the aged clot, and to monitor response to therapy. So pathophysiology of thrombus formation. So if we look at the steps involved in formation of a thrombus, first it is the platelet aggregation, and platelet forms the primary plug. And then there will be activation of the coagulation cascade, and there will be a fibrin formation, fibrinogen to fibrin. So that will be deposited and the secondary clot will be formed. Then there will be recruitment of leukocytes, macrophages, and inflammatory cells, and thus a clot is formed. Then, as time progresses, the clot will undergo organization, recanalization, and fibrosis. So, in early thrombi, there is a high metabolic and cellular activity, while in chronic clots, they are more fibrotic and inert. So, the metabolic activity decreases over time. So if we look at the etiology of thrombosis, we look at Witchhorse triad. So endothelial injury, hypercoagulability, and abnormal blood flow. These are the important causes of thrombosis. So once there is first platelet plug or the activation of platelet happens, then comes the coagulation cascade. So there are two pathways, intrinsic and the extrinsic pathway. Intrinsic, we use activation of factors 12, 11, 9, and ultimately activation of factor 10 to 10A. So in extrinsic pathway, there will be endothelial injury, release of tissue factors from the endothelial injury, which will activate 7 to 7A, which will directly activate 10 to 10A. So at last, 10A will activate thrombin. Thrombin will activate fibrinogen to fibrin. So if we look at arterial thrombosis, this is like most commonly, it will be endothelial injury. That will be the trigger factor. So for example, there could be a atherosclerotic plaque rupture or something like that. Then when there is endothelial injury, subendothelial collagen will be exposed. So in the subendothelial collagen, there will be von Willebrand factor and exposure of these GP1B receptors. So exposure of von Willebrand factors, and like the platelet will be adhere with this receptor, GP1B receptor, and there will be platelet activation, and which in turn, then the second step will be coagulation cascade. So coagulation cascade will ultimately result in activated fibrin formation, and then there will be a arterial thrombus formation. So the most dominant pathway here is the extrinsic pathway. This pathway is more common in arterial thrombosis. So the thrombus type will commonly be a platelet-rich thrombosis, or it is also called as white clot. So the molecular targets will be activated platelets. So this we'll talk about later. So activated platelets will be a specific molecular marker for this. So when we come to venous thrombosis, the most common trigger will be blood stasis, hypoxia, or inflammation, rather than the actual injury to the vessel wall. So the dominant pathway will be an intrinsic pathway, and the thrombus type will be RBC and fibrin-rich clot, which is also called as a red clot. So the molecular target will be fibrin. So, but fibrin is not specific to a venous thrombosis. It can be seen in arterial or venous thrombosis. So we'll talk about the traces later. So if you see, first there will be platelet plug formation, then there will be clotting factors activation. So here these are the activated platelets. First platelet plug, then the mesh-like thing, that is the fibrin strands. So they will form the insoluble clot. So pathophysiology of thrombus formation. So both the intrinsic and extrinsic cascade at last they converge and they activate factor 10, followed by thrombin and then followed by fibrin formation. So if you see, there will be platelet activation and fibrin cross-linking. So once this fibrin is formed, then it is stabilized by factor 13, fibrin stabilizing factor. So we have traces specific for that as well. We'll talk. So next, pathophysiology of thrombus maturation. So in early thrombus, there will be platelet activation and fibrin deposition. So these are the most important things. Whereas in the later phases, the platelet activity decreases and fibrin is also replaced by collagen and fibrosis. So if we take platelet activation specific targets or the fibrin specific targets, it is more likely to pick up a acute thrombosis, not a chronic thrombus. Then this thrombus, it might undergo either resolution or propagation of thrombus, that is the increase in size, or thromboembolism. There are small bits that might get lodged in smaller vessels, or it might undergo organization or later recanalization as well. So the blood flow might be restored, but it will be reduced or narrowed. So conventional imaging, we know USG, maybe Doppler duplex, CT or MRI angiography. So they detect filling defects or flow alterations, which are actually indirect evidence of thrombus. But these have slightly lower sensitivity and specificity. So they can differentiate between an acute or a dormant thrombus. So if we come to PET-CT, it is quantitative. That is like we can measure the SUV, high sensitivity and non-invasive imaging technique for thrombus imaging. So actually what we do is we take PET-CT or PET-MRI. So the CT component or the MRI component, they will give the anatomical detail, whereas the PET component will give you the metabolic and the molecular details. So we can detect small and early thrombotic events which may be missed by structural imaging. So PET-CT is basically it gives more information than the conventional imaging. So radiotracers used. So F18 FDG is the most commonly and widely used PET tracer in clinical practice today. There are many specific radiotracers specific to thrombus, but they are still under development or in the early clinical pilot studies. So molecular PET imaging, we use radiolabeled molecular probes that bind specifically to thrombus. So this will increase the sensitivity and specificity of thrombus detection. And we can also assess the age of the thrombus, if it's active or acute or a chronic thrombus. And also we can assess the activity and composition also. So it is still in experimental, not in routine clinical use. So these are the commonly used radiotracers. We'll see. So first, fibrin based, when the target is fibrin, The radiotracers are F18 or copper-64 tagged with fibrin binding probes, 7 and 8. FBP 7 and 8, these are the commonly the most prominent ones. Then if the target is activated platelets, F18 GP1, like protein 1. And if it is factor 13, which is the fibrin stabilizing factor. So F18 ENC 2015. This will target the factor 13A. So this is what this sums up. So intrinsic and the extrinsic pathway, they converge at 10, then thrombin, prothrombin to thrombin, then fibrin to fibrinogen. So fibrin, these are the two commonly the major radiotracer that will target the fibrin. Copper 64 tagged with FBP 7 or 8. Then for 13A, it's F18 ENC 2015. And activated platelet, if it's F18 GP1. So F18 FDG. So FDG is a glucose analog. It is taken up by metabolically active cells, which might be inflammatory cells or tumor cells. So in thrombi, especially in early ones, the inflammatory cells like neutrophils or macrophages, they have increased FDG uptake. So thus F18 FDG PET-CT is still the mainstay and the most common modality for looking at clot activity and to differentiate if it's a benign or a malignant thrombus. So if you see, this is an example of 88-year-old patient with renal cell carcinoma. So they are having here, if you can see, this is the clot and it corresponds with a very high FDG uptake. This one. So this clot is here and this one also takes a very, so there is a tumor thrombus from the renal cell carcinoma. The tumor thrombus has invaded into the gonadal vein and the renal vein, extending up to the extending up to the IVC as well. So if you look at Thrombus-specific PET tracers, these are the ideal traits which they will expect. So high specificity for clot or inflammatory cells, low background signal in the blood pool, favorable kinetics and clearance, good stability, safety and feasible half-life, good signal to noise for small vessel lesions. So first we look at fibrin. Fibrin as a molecular target. So fibrin, it is present in high concentration in both arterial and venous thrombi, but it is absent in circulating blood. So the background noise or anything like that will not be there. So it has a high specificity for thrombus detection. In acute thrombosis, it is very helpful, but in chronic clot, the fibrin is actually replaced by collagen. So it cannot detect the chronic thrombus. So if we look at fibrin binding probes, FBP, they are developed specifically, they are the specific PET radiotracers targeting fibrin. So commonly the major ones are the FBP 7 and 8 tagged with copper 64. They are actually short cyclic peptides labeled with copper 64. They have high affinity, high selectivity for fibrin, whereas they do not bind with fibrinogen or fibrin degradation products and all. They have high specificity for the fibrin, that is the activated fibrinogen, only the fibrin. So these are some of the animal studies and early human studies that are done actually. So first study by I et al. They used the mouse model. They have made a fresh carotid artery crush injury and an internal carotid thrombus by injection of thrombus. So like they detected like fresh and aged thrombi accurately. So this was the first finding, first animal studies that was done, and other studies as well. So this was in left atrial appendage thrombus detection in patients with arterial fibrillation, atrial fibrillation. So this is that example. So this here we can see the internal carotid clot here, but after giving the RTPA, that is the recombinant tissue plasminogen activator, the clot was destroyed, and that was not seen actually. That was a mouse model. So next, platelets as a molecular target. Activated platelets are key markers for acute thrombosis. So actually, platelet has several surface receptors, which can be a potential target for molecular imaging. So if we see this target, glycoprotein 2B3A, it is actually present in activated platelet, not in the normal platelets. And it will be abundantly present, like around 60 to 80,000 per platelet. So when it is activated, it undergoes allosteric activation. That is, it switches to a high affinity state for binding with fibrin or fibrinogen. In that time, this target will be activated. So, and this will be critical for platelet aggregation and thrombus formation. If we target this, we can actually measure acute vascular thrombus. So, radiotracer which targets this protein is this glycoprotein 2B3A receptor is F18GP1. So it is a small molecule analog of Elarofibin, which is a GP2B3A antagonist. It binds selectively to activated platelets, which have these receptors, and it has high affinity and specificity even after radiolabeling. So these are some of the studies that have been done with this new radio tracer. So this GP1, F18GP1 is the most extensively studied platelet-specific PET tracer. It enables direct visualization of activated platelet aggregation, which might tell you that it is an acute thrombus. So the potential clinical applications include diagnosis, monitoring of antiplatelet therapy, and thrombus characterization. The next target will be activated factor 13, that is 13A. So F18 ENC 2015, this will bind specifically to the activated factor 13, and it has a high specificity for acute thrombus. Here the ENC stands for elastin-like nitrile compound. That is, it denotes that it is originally derived from a nitrile compound. So that is the chemical series name. But this is not used now because of excessive renal radiation exposure in the dosimetry model. So this has been withdrawn completely now. So clinical applications. So first will be to distinguish a benign thrombus with a tumor thrombus. So if there is if we are doing a PET-CT for an oncology case, it is very important to differentiate a benign thrombus from a malignant thrombus because the therapy or the treatment planning will be totally different. If it's a anticoagulation therapy, this is an oncological intervention. So if you look at a bland thrombi, it will lack viable tumor cells. So it will show minimal metabolic uptake compared to the background. But if you come to a tumor thrombus, it will actually show a arterial phase contrast enhancement in CT or MRI. When coming to PET-CT, it shows a higher metabolic activity. We can see contrast enhancement in the CT component as well. And if it has other characters like infiltration of the vessel walls, it mostly denotes a tumor thrombus. So coming to SUV max, so based on some of the studies that are done, for example, first in liver cancer with portal vein tumor thrombosis. So if there is a portal vein tumor thrombosis, it denotes poor prognosis. So studies have showed that if it's a tumor thrombus, the SUV max is significantly higher than a benign tumor. So this is a retrospective study done in 38 patients. The SUV max was 6.25, a mean of SUV max in tumor thrombi were 6.25, whereas in bland ones it was around 1.79. So if we have a cutoff of around like more than 3.5 with high sensitivity, we can discriminate a tumor thrombi from the bland thrombus. Next, we'll coming to renal cell carcinoma with venous extension of the thrombus. So this is also a study with 655 patients. So the SUV max of tumor thrombus was around mean was around 6.25, whereas bland it was 2.1. So, but then we can't. The SUV might differ according to the imaging protocols and as per based on the scanners and many other criteria. So there they developed a metabolic ratio. So here in this study they have done SU that is the standardized uptake value of the tumor to the lung. So this is the thrombus to liver, that is SURL, or the thrombus to aorta, SURA. So if they calculate it as a ratio, the optimal cutoffs were kept at 0.953 for the SURL and 1.42 for SURA. So that was also differentiating a benign and a malignant thrombus. So not only SUVs and these ratios, we can also see other things like if it's a focal nodular uptake, it is more in favor of a tumor than a linear uptake. If there is vessel expansion or irregular margins on the CT component, or there is a contrast enhancement, or if there is a invasion in the vessel wall, all these point to a tumor thrombus. So this is one example, 83-year-old patient with thymic thymic carcinoma. So we can see bilateral internal jugular veins. They are showing a good FDG uptake as well as in the SVC. So here you can see the thrombus. So that is also taking up in the FDGs. So this is a hepatocellular carcinoma here. So it has a tumor thrombus invading the portal vein, right portal vein. So that here we can see to be taking up the FDG more. So this more likely it is a tumor thrombus. Next clinical application in venous thromboembolism. So if we look at patients undergoing FDG for any other oncological reasons, incidental findings of DVT or pulmonary embolism might be seen. So if we see in FD in the PET component, there might be a incidental focal uptake along these venous segments. So that might give that might add more value to the diagnosis of DVT or pulmonary embolism. So we can also use specific tracers like F18GP1, which is targets the activated platelets. So this is a case. This is a normal control patients. Here we can see DVT taking up FDG in patients. Next, thrombus age estimation. So early thrombus, there will be inflammatory cells and there will be increased metabolic activity. So more FDG uptake. Over weeks, it organizes and the activity declines. So in a prospective study, it was seen that FDG uptake was seen in acute DVT segments, whereas over time, it actually reduced. And we can also see that if it's a chronic DVT, the uptake was actually reduced. So thus we can use it to differentiate if it's a fresh thrombus requiring active therapy or it is an old stable clot. So if you see this is a patient after he had DVT. After 21 days, the SUV was 3.83. And at 55 days, it was 3.03. And at 70 days, it was 1.88. So as the age of the thrombus increases, the activity actually decreases, but we do not have a specific cutoff or anything as of established yet. Then this is another case of DVT. Here you can see first initially the SUV was 2.28, then it was 1.99, and it was 1.77 at 42 days. And monitoring response to therapy. So initially, if we detect a PET CT, detect a clot in PET CT, after therapy, it might show a decrease in the metabolic activity. So we can assess the response to the therapy, and we can plan for further therapy if it's needed, or if we should escalate, or we should go for surgery. So disadvantages and limitations. So sensitivity issues might be there because bland thrombus often has a very low metabolic activity, sometimes indistinguishable from the background. And a small thrombus, all those we can actually miss due to partial volume effects. So blood pool background and spillover. So high activity in the blood pool, especially if we are taking a early imaging after injection, it might obscure thrombus uptake. So that might be one of the reason, and there will be a partial volume effect, that is the spillover from the adjacent structures, especially if the clots are very small. And if there is infection or acute inflammation, it might also show a increased FDG uptake, like infection of the chronic thrombus also. So that might be a false positive. And catheters, vascular stents, all those can cause artifacts. SUV variability, it might be due to the scanner calibration, reconstruction algorithms, patient preparation, time of scanning. All these can change the SUVs. Like so, so there is no specific SUV cutoff, but we have seen from the studies that 3.5 might be a cutoff that we can helps to differentiate it more specifically and specifically. So to counteract this SUV variation, metabolic ratios like the thrombus to liver and thrombus to aorta ratios can be used. Next, the radiation dose and cost. So cost is also high. There is the radiation dose is also comparatively high to the standard conventional imaging. So it is not routinely used. So first, PET CT or the MR angiography are the most preferred imaging methods for a thrombus. Then lack of large prospective trials at that is also one disadvantage or a limitation. Then the clot might have a heterogeneity within a clot, and and also it might be difficult if the clot is very adjacent to a tumor or there is a increased vascular uptake. So summary, so thrombosis, it is the formation of a blood clot within a blood vessel. So conventional imaging provide anatomical and hemodynamic information. So the radiotracer use are F18 FDG, that is the most commonly used. Some thrombus-specific markers are fibrin-specific, it is F18 or a copper 64 tagged with FBP 7 or 8. For activated platelets, it's F18 GP1. Activated factor 13A, it's F18 ENC 2015. So this is what it's up. Some fibrin, these are the things, and for 13A and for platelets. And the uses of PET CT, it is to differentiate tumor thrombus from bland thrombus, to estimate the clot age or activity, to monitor therapeutic response, and to detect occult thrombosis like DVT or P. These are my references. Thank you.